So Angeles, I think that was very helpful, and I appreciate that. Let's define some of these terms because they're so important. So BRCA repairs double-stranded DNA breaks, and other genes involved in that create difficulty in repairing double-stranded DNA breaks, and that's called homologous recombination repair deficiency. Tom, we haven't gotten you involved yet. How do we test, or how do we test patients for BRCA or HRD, or what's the current state of the art in molecular testing in epithelial ovarian cancer?
Well, there's a lot of ways of approaching it. Currently, it's recommended all epithelial ovarian cancers are tested, and that's a blood test, so that would be germline testing that goes on.
Test for what now?
Testing for BRCA.
Okay.
Now, there's also others who are raising the hypothesis that perhaps we should be testing tumor as well, and then reflexing. So there's a lot of different things out there, but I think the important take-home here is that we recommend that all people, all women who have an epithelial ovarian cancer are tested, and there's several implications from that. Obviously, it has prognostic implications in terms of how the patient's going to do. They're going to do better. And then now we have drugs that are available, either approved or on clinical trial for treatment. And then, of course, you have the concern of what this means for the family at large, so cascade testing for other members of the family in terms of identifying carriers for BRCA, which has significant implications in terms of risk reduction strategies.
You know, I'm always struck that when I see a patient in consultation that's had epithelial ovarian cancer for a long time, and she's never been BRCA tested, even though it's ASCO, Society of Gynecologic Oncology, and NCCN level 1 testing. Yeah. The idea of testing the tumor, I think, is new. Those are certainly somatic, but also germline together. If a woman has a germline mutation, obviously the tumor has it too, but the opposite is not true.
Right.
So you could have a tumor mutation but have it not be germline. Tell us about somatic or tumor testing. Are you doing that yet, Katie?
We're doing it, well, actually, there was a test that was just approved on December 5th. We can now test for homologous recombination deficiency through sending a sample of tissue tumor in, and they'll run this homologous recombination deficiency test and give you a score that you're positive or your patient's positive or negative. So it won't tell you a specific somatic mutation, but if you have a somatic BRCA mutation or another important somatic mutation in the DNA repair pathway, you're going to show up in that homologous recombination positive group, and that could potentially someday reflex you to germline test. I don't think we're there yet, but that's one test that's now available to do.
So I know what to do with the germline mutation. The genetic counselor's involved, and we deal with the kindred and risk-reducing surgery, and I tell her that her prognosis is better if she's germline mutated, and I try to get her in a clinical trial. What do I do with an HRD test? I get it. I get it that it exists. What do I do with that now?
So I think the kind of a key point that was brought up here is that it's probably more important right now to just understand that the machinery is messed up, so that the ability of the cancer cell to fix itself, which ordinarily is
double-stranded DNA breaks,
right? That that then becomes a vulnerability you can take advantage of if you can promote that in the cancer cell. So that's the idea of the whole synthetic lethality that we talk about in the context of the PARP inhibitors, but it applies across other things. Anything that can cause DNA damage with an imperfect repair mechanism can lead to lethality. And so that's why we see some better outcomes prognostically and predictively of using drugs that have direct DNA damaging, platinum, liposomal doxorubicin, other DNA damaging agents that actually produce better outcomes than expected in the same patient population.
So Angeles, what's the connection then to PARP and BRCA or HRD?
Well, we're going a whole next step, but this is a great conversation and a great question. So what happens here, and Rob alluded to this, with something called synthetic lethality. So if somebody has a BRCA mutation, whether it's germline or somatic, or they have another defect that's causing this loss of homologous recombination, then the cells can't repair themselves once they're subjected to a DNA damaging event. All right, that's where the PARP inhibitor comes in. So you have this cell that can't repair itself, gives us HRD, it's deficient homologous recombination. Then you add the PARP inhibitor and you block another mechanism of DNA repair, and much more likely to shuttle that cell toward apoptotic or death pathway.
So PARP inhibitors inhibit single-stranded breaks. If you can't repair a single-stranded break, you get a double-stranded break. And if you have BRCA or BRCA-like gene, you can't repair a double-stranded break, the cell dies, and that concept is synthetic lethality.
Yeah, and I think that's the kind of the general cartoon that we all have in our mind. It's the easiest thing to understand, but I think it would be minimizing the science if we didn't say that there were multiple other mechanisms involved with that. And so one of the ones I find that's quite interesting is that PARP actually regulates a poor fidelity pathway of DNA repair called non-homologous end joining. And so when you inhibit PARP, it actually takes the brakes off of that.
Right.
And so that there's preferentially then a line of development that goes down into that non-homologous end joining pathway where more mistakes can be made. So there's other options.
I think there's two things to emphasize here. One, we talk about DNA damage and how many times the cell has to address this. The modeling I've seen is amazing in terms of the number of times in a day that you have to address this.
Depends on how much alcohol you drink. Does that constitute DNA damage?
That certainly could be related. A number of environmental issues could
Oh, there you go.
be-
Sorry.
Yeah.
But to Rob's point, the shift to, so the repair takes place. It's just that you shift from a high fidelity to a lower fidelity system with the non-homologous end joining, for example. But there's other
And I'm
pathways
struck
as
by
well.
the idea that in these HRD cells, because the fidelity is not high, there may be more neoantigens, and it may be an opportunity for immunotherapy. But that's